Oh, right. Good evening, everyone. So I wanted just to introduce Sally Ann Wherry to the Research Hub for May. And Sally Ann's a senior lecturer at the University of Gloucestershire in the School of Health and Social Care. So Sally Ann's going to talk about her PhD, which is the intergenerational impact of the contaminated blood scandal. So, Sally Ann, I'm going to hand over to you now, if that's okay, to
That's
present,
absolutely fine.
and then we'll obviously pick up any questions at the end. Thank you.
I'm going to request to share. So
Yeah, and I'm going to press allow.
there we go. Let me pick the right PowerPoint slide thing. There we go. I don't know why it's trying to open EndNote. That's not something I've asked it to do. That's weird. Okay, so my research is very personal to me. As as Emma said, I'm a nurse specialist. Actually a nurse in movement disorders. Um, and my PhD is in, as Emma said, the intergenerational impact of the infected blood scandal on families with haemophilia, very specifically. I will give you some trigger warnings. There is death, there is grief, and there is trauma in this, obviously. And I will most certainly get emotional because of the nature of my connection with the topic. To give you a little bit of background, haemophiliac is a genetic condition, which means that families with haemophilia have to interact with the people involved in or at least the centres involved in the scandal. And what happened during the scandal was people were infected with hepatitis and HIV, not just the haemophiliacs themselves, but their families. So it was passed to partners and it was passed to children. And people were included in drug trials that they weren't aware of. They were tested for diseases without being told. They received diagnosis of diseases without being told. So there were people out there with HIV who hadn't been told that they had HIV. And there were conversations with doctors where they felt comfortable discussing whether they should tell people who were trying for children that HIV might possibly pass down. So it's an incredibly awful scandal. And my generation were haemophiliac carriers. So it's well known that you've got a 50% chance of having a haemophiliac son if your father was a haemophiliac and you have had that carrier from them. And what that means is we have to take our sons to the specialist centres where we have to make the same decisions our forefathers did about treatment, whether you take that new treatment, whether you give that treatment to your child, whether you engage with the centre and how much you engage with the centre. And for my generation, it's very difficult because you're thinking of this every time you go in. And that's what I thought when we were going through. When you look at some of the figures, 3,800 children were infected with HIV. And the way people were informed of that was brutal, with no psychological consideration for safety of anyone. And in one case, the children were told, but the parents weren't, where they were infected at a school, which is now currently being sued by its remaining students. Mm-hmm. So it's a really large scandal in our community. And I'm one of the affected. When I was a child, my father was infected with hepatitis. And so we've lived with those associated health things. You can see him being slightly yellow in the picture and slightly rotund in certain areas. And that's me standing with my little sister being cradled. So I have to really think about what it is I reveal and what I conceal in my research, how I manage my biases. I have to really be thoughtful and reflective. And that's why I'm going to get a bit emotional during this talk, because these are themes which really deeply resonate with me. And so I have to think about how I manage that bias, how I think about the emotions, how I safeguard myself, because I'm sitting in a room talking about the same situation we could have been, or the situation we were in. And to do that, I use a methodology called autoethnography. That's where I include my experiences within my data. I apply serious reflective practices to keep in mind the decisions and the responses I'm having. And there are papers out on how I do this, but one of the things I did, for example, was I sit in the car after the interview, and I record what I'm thinking, what I'm feeling, even down to what I'm feeling in my body, and then I transcribe it, and then I put it in with the rest of my data. So I take an interpretive viewpoint, because from the perspective I'm coming from, it's the only way I really can make it sense. It's interpretivism says there isn't a single truth. There's no single nugget. We can't grind the universe down and find a piece of information, a molecule that says this is how these families feel about it. So there's no single truth. There's only their experiences, and we can only say this is what that person felt. This is what this person felt, and here's the sort of vibe of what happened here. To steal a word from my daughter, this is kind of what this picture looks like for all of these people in different ways. And I've made a type of autoethnography called relational, because it's wider than autoethnography, which is where you examine your experience. It means writing about self, the study of self, with writing it down, or performing it, or in any other way you express it externally. And that is really good for researchers who are sitting in that field, sitting in that space. So there's a thing called a complete insider status, where you are an insider in that world. And that for the haemophiliac study, that's particularly important, because for some reason, haemophiliac families aren't that keen on researchers. You can't think why. And so exo-autoethnography is an extension of that. But what it does is it looks at a generational shift. And it's the study by somebody who's the child or grandchild of someone who experienced the thing. And I started out in exo-autoethnography thinking that I had no experiences directly myself. And then halfway through, I discovered that the abortion I was offered when I finally got pregnant with my daughter by the doctor who'd been helping me get pregnant with his lovely drugs was a policy from our haemophilia centre. And I was like, I smell eugenics in the air. Yeah. So that was one strand of my research. It still is. I still have to do that as I'm writing up, as I'm considering. The other part was qualitative, where I interviewed the children and siblings of those involved with the scandal. So I interviewed young women who'd chosen not to have children, young women who'd chosen to have children, ones who had haemophiliac children, ones who didn't, and the male siblings and the sons of haemophiliacs. And it was thinking about who to include was a whole reflective thing in itself. I chose to exclude people outside of the haemophiliac group. I used semi-structured interviews, which I call conversations. Most of them I went to people's homes, and I sat there while their kids were in the next room. I sat there having coffee. And it was a really reflective thing to judge how much to reveal of myself, how much would skew their story if I told them my story first. So I gave them minimal information before, usually, just that I was the child of a haemophiliac in this situation. And I didn't really give them full experiences. And often afterwards, we'd have a conversation and a coffee and a debrief where I revealed more of it. And that was incredibly powerful. And there were times where I was very authentic during those interviews. I did at some various points sit there and cry with them. There was one interview where we had to stop recording while we composed ourselves, because you can't really transcribe two grown women sobbing. So we were interviewed at home. We sat, and some of them we interviewed on Teams because they were too far away. I gave the choice to them. I was happy to drive to where they were, apart from the one in America who'd moved to America. I didn't really want to go there right now for some reasons. Each transcription was then participant checked. So I went through and checked it for sense, because Teams doesn't always quite transcribe what you're saying. It can make some wildly inaccurate decisions. And then I sent the transcript to the participants, and they chose to open it or not. They chose to edit it. They chose to work with it themselves, to correct things, to add things. And with one person, I worked deeply with her to conceal her identity. because she, as a participant, she's quite identifiable. And so I worked very closely with her. We changed genders, we changed locations, we added a sibling that didn't exist, stuff like that. So my numbers are few, but really rich in information. One interview was 3 hours long, for example. So we spent a lot of time talking. And I was really in awe of the courage that they showed and the willingness to talk about their deepest feelings. One had never spoken before about stuff that had happened with him at the specialist centre, and he'd never told his wife about a lot of the things. And he even though he was seeing his therapist, he hadn't told his therapist some of the stuff we talked about. And in a number of times, I had to strongly encourage people to engage with therapy afterwards. But being very careful that as a nurse, I wasn't taking my skills to become a therapist in those interviews. I had to be very mindful that I was a researcher who was interviewing for that, and I'm not a therapist there to fix or heal. But also equally be mindful of the trauma and try not to stand on any minefields. And that's really hard. That's really hard to do. I made a slip where I asked a question and the man wasn't aware of that section. And he decided to withdraw, and that's fine. That is entirely his right. So it's a really delicate balancing act when you're talking to people, A, with that level of trauma, but B, in the same community as you. I also had to think about things like when I saw them at events, when I went to the inquiry and they were there, me not talking to them first, me letting them make the decision whether to talk to me as a known researcher. It's quite hard if you've sat there and cried with someone not to approach them when you see them. But it was and I warned them that I would do that in advance. I using reflective thematic analysis for good old Braun and Clark. And I use them Vivo because I'm a bit of a computer geek and I like a nice computer. So it's very tidy and neat and controlled. I like that. And I came out with 4 key themes after coding and sitting down and going. And those themes were really powerfully present in almost every conversation I had, but particularly with the young women. And I'm going to show you a few of the quotes to illustrate them. So we very much know that adverse child experiences have a massive impact on people's health, education, relationships, and opportunities. It was really clear in every person I spoke to, apart from one, that those early disruptions resulted in a delay in their life path, between 5 and 15 years delay in some cases. And for all of them, it impacted their economic status. And for one of them, it's still impacting it. He got refused a mortgage on the day of my arrival, because his income wasn't good enough and because of his status. So it was really clear that that educational disruption particularly was related to the family support needs or their mental health, which came from this. We found that a number of them had left home really early, that many of them had struggled with addiction, substance misuse, and really harmful relationships. A few of them had ended up in outrightly abusive relationships. A lot of the women had struggled their whole lives with self-esteem. And the parental trauma had really been shown to travel down with the parental ACEs, which they'd experienced, impacting their life paths. And there was one case where we can see it going to the next generation, which was really, really traumatic for her. This silence and secrecy was a really strong theme, particularly for the siblings and daughters. It was affected in both. Where their education had been disrupted, there was parentification going on as well, where they were taking care of their siblings, or they felt that they couldn't burden their family by talking about how they were feeling. So you had, for example, one sibling whose brother told her at the age of 7 that he had AIDS. When they were sitting in the back of the car, she went to punch him, and he said, "You can't hit me, I've got AIDS." And that's how she found out. And then she's told as a 7-year-old, you can't tell anyone. We're in a little rural village, you cannot tell anyone. And overnight, she can't talk about this big thing. She can't talk to her sibling because that's the one who's dying. And she can't talk to her parents because they're the ones with the dying child. And so suddenly she's just completely isolated. So we really saw it was particularly evident where the scandal impacted those early years, and particularly in the siblings. One was left abruptly to be the parent for her younger siblings as her dad was dying, and her mum just vanished off. And she's, I think, 12, 13, and she's in charge of getting them to school, getting them fed, and doing everything. All of a sudden, literally overnight. And so this was in a time as well where reaching out for help would be fairly impossible, where the stigma was so powerful that one of these families were asked to remove their children from school because they were the AIDS family. And so it's a time where they can't reach out. Even after they left home and after they entered into relationships, they found that they self-silenced. They stopped being able to ask to have their needs met because they didn't know how anymore. More than one hadn't spoken to the trauma they experienced to anyone else. And the inquiry that we've been through meant that they had to open up that wound, but not just open it up, see it on the news and hear about it over and over again all the time. And have people ask them, because you're known to be a haemophiliac family, so are you involved in this? And with the stigma of AIDS in your background, are you involved in this comes with a weight. So they had to share their stories in the most formal of settings, sitting with their lawyer. And some of them had received replies from the trusts involved, the clinicians involved, that were really painful for them to receive. As one of my participants put it, his brother received one that sent him on a bender. So some of the more recent narrative as well about how much we're costing the government opened yet another wound for them. And the mental health support is really limited in nature. It's really difficult to access. And right now, people are still fighting to have their mental health supports remain in place. Where there's loss and where there's unresolved grief, it can lay a foundation for 3 to 5 generations to recover. We found the beginning of this pattern in the mental health struggles. We saw the impact from early childhood through to adulthood, from people who'd had sought counsel in their middle age and found healing, to other people who still hadn't spoken about it. The delay in truth and justice is another impact for them. Several compared it to being unable to bury and grieve, or to digging that person up again, because they keep having to go back. For others, it's been healing to talk about it. But equally, you can see the massive impact on their mental health struggles here, where most of the young women had at some point or other problems with their mental health, and half of the young men had. And so it really impacted their ability to function at all. Every single person we spoke to lost their trust in healthcare in general, but very particularly in the specialist centres. One comment particularly, it's on the bottom there, particularly illustrated the ongoing harm, and it really showed the need to provide that trauma-informed care. Even those who appear to have a really good relationship with their teams think of the scandal with every treatment. So one person said to me, every time I press that needle, every single time I think about it. And there's some recent studies by Peter Fletcher and his team around gene therapy. And they looked at why particularly people aren't uptaking the new gene miracle drug. And I thought the answer was fairly obvious. But some of the answers aren't obvious, but this is one of them. One sibling who is also a haemophiliac has opted out of any specialist care. He uses his GP and he uses the emergency room if he has to. And he will not go in. In 2 other cases, the entire family have not taken the COVID vaccine because they don't trust that treatment is safe. And they don't trust the people telling them it's safe because that's what they told them last time. With the mothers particularly, they struggle to contain their fear of going into the same unit, sometimes with the same staff and their children. We saw repeated re-traumatization from the point of conception right the way through. So and you can see the need for sensitivity for those women whose prenatal care, there wasn't much trauma. That was a really low level of training and the high level of re-traumatization, alongside the common problems of giving birth to a child with a rare bleeding disorder that has increased risk during pregnancy and childbirth. We've also got geotrauma, where they're walking onto the same site their parents were infected on, their fathers died in, interacts with some of the same staff. This was particularly harmful when the interaction was unexpected. Each time the woman was powerless to change or influence the situation. The ones in control there are the organisations and the staff. And there's some places where we saw a marked difference in the way that was managed. There were some really excellent examples of nurses in allied health who make those relationships. This is usually in paediatric services, where the mothers felt supported in some of them and heard, and the children didn't show any signs of fearing the hospital any more than you would for someone who has to go in for regular painful events and needles. So even in some areas as well, even the needle phobia was handled in a way that was supportive, person-centered, and trauma-informed. So it was really good. And what out of this, I really want you to think about the trauma-informed treatment required, because haemophiliacs do pop up everywhere. It's like, you know, we may have car crashes near Gloucester, we may need surgery. So it's really about taking that learning forward and saying, what are we doing to make that safe, psychologically safe? And this, I feel like this is the most important slide to show you. I want to leave you with this slide, which shows you the lessons they want us to learn. Because the last question I asked was, if you can talk directly, what would you tell them? And this is what they want to tell people. So there you go. Short and sweet. Well, comparatively short.
Thank you, Sally Ann. It just reminds me, I worked in London in the early 90s, between 1990 and 95, and I was the high risk coordinator when I worked as a podiatrist. And I would see people with HIV and AIDS because they would come hundreds of miles away for their treatment in London. So the Cobler Centre at the Chelsea and Westminster was like the centre of excellence, and obviously it was linked to Charing Cross. And I can just remember this one chap. I mean, you know, obviously he's under different circumstances, and he had AIDS, and I think his mother was a physiotherapist in Cornwall. He couldn't tell his mother he was dying, basically. You know, every week I saw him, his T-cell count was going down, and he was spreading verrucas faster than I could treat them, and sort of fungal infections. His immune system was kind of rock bottom. And it's just, I mean, obviously that was on the early 90s, the stigma, the absolute stigma of that he experienced, and the fact that he couldn't even tell a family member, his own mother. And he was a grown man, you know, in his probably, I think he was late 30s then. And yeah, it just sort of reminds me of the stigma that exists. I had one question actually. I was just interested, obviously I appreciate this is the kind of intergenerational impact, but in your PhD, were the views and feelings of the staff captured at all? Because I was this is all just
that's something I'd like to do.
Yeah, I'd just be interested, because I think there may be some staff who are kind of living with trauma as well, definitely. I would imagine. Yeah.
I think there's also staff who are getting vicarious trauma. Because I presented to a bunch of nurses at an international conference recently and made a couple of them cry, which meant I was reaching them. But I had a number of them come up afterwards and say, I haven't realized that. I didn't know I was making, and the trauma, I could hear it in their voices. And I'm working with one at the moment to design some education, to look at their service and say, can we make this more trauma informed? To have an actual trauma assessment when you look at a family, and go and not have it as a label dad involved in, but have it as this is how we feel, this is the information need I have. But I felt at the beginning of it, because I thought about involving the staff, and at the beginning I thought, actually I'm too angry. I'm still, you know, my father's consultant is dead, luckily. because I don't know how I'd have managed myself with him going up on the stand like other consultants are. And this last month, a consultant published a letter saying, didn't this drag good people's name through the mud? And I'm like, if you gave AIDS to babies knowingly, you should be dragged through the mud. you, you can't be a good person if you've done that. So I my thesis title is going to be Bleeding Liars, because
Right.
that's what my dad
Good one.
he
I
read
like,
something.
yeah, I like that. I have to say, Sally Ann, I actually nursed these patients. And with I worked at the Royal London as a senior nurse, and I actually infection control was my specialty area. And this was when they had been infected, but we had a big haemophilia centre, and I was constantly getting these poor people in and seeing them in the state they were in, the Kaposi's sarcoma, the mental distress that they were
Yeah,
in, and it I have to say, I mean, I wasn't involved in the actual haemophilia side of
no,
it,
but it
but I
is
was involved
traumatic.
in responding to the patients who had then contracted HIV and AIDS and were dying in front of my eyes.
Yeah,
Um, and at that time, it was so distressing for a nurse looking after them.
yeah,
And to see that, and you're right, many were alienated by their families.
yeah,
And but just to see the distress of seeing a loved one who had already got a condition that they were having to live with, that was,
yeah,
an easy life anyway. I know my son's a very good friend was haemophiliac, so I know what it was like. And but then to have this piled on them, and they were dying, and they
yeah.
were and the distress to them personally. But I suppose what stuck in my mind, and it was one gentleman who got terrible Kaposi's sarcoma, and I found him in the sluice drinking washing up liquid because his mentally he'd just gone. And
Yeah,
it's small bits like that, and you think this was a man who held down a responsible job, who had a good life, good family, was living well with his haemophilia, and his whole life had been destroyed, and his family's life had been destroyed. And yeah, you know, I did it as a distance, but I was caring for them, and it was the most really distressing thing to ever see. And you just hope
it
you'd
was
never
horrific.
nurse anything like that ever again, because to nurse a patient where they have been damaged by the health system
Yes,
is awful. We nurse people with cancers and all sorts of diseases they might have inflicted on themselves, smoking or whatever.
yes.
Um, but to see this, it was awful, really, really. And these patients still stick in my mind. I can still see them there. So I do have an understanding of what you've gone through and how difficult this probably was for you to do this study.
I can honestly say it is one of the most hardest things I've done.
Yeah. But almost, did you
Um,
feel you needed to do it? Did it help in
I
that sense?
felt I'm angry, and one of the things I've heard more recently is a number of consultants said are like, well, the haemophilia should be over that by now. And one of the things with the genetic disease is my father's haemophiliac, my uncle was, three of my cousins are, my great nephew is, my nephew is. So in one family, it's not just one person who died. And maybe if it was one person and people hadn't done it to us deliberately, we could get over it.
Yeah, yes, exactly,
But
yes. But
it's,
but it's bigger than that, and you can see what you've described there is so generational. That impact continues, doesn't it? Which is obviously what
yeah,
you were looking at. I've got a couple of points. The um, did you find um because you had that personal experience, and obviously though you didn't go into detail when you started the interviews, you did let them know that you had personal experience. Did you find that helped give you that inroad into those interviews? Do you
it
think
was
it
the
helped?
only way no one outside of the community could get an interview.
No, so I wondered.
When I was working to design the adverts, for example, I had some stakeholders from the campaign groups, and I sent it to one, and he said, "You've got to take the word research off that.
Mm.
You can't have the word research. No one will talk to
That
you
would
if."
put them right off. Okay.
Yeah. So, and I'm really lucky that the campaign has helped me. And it's a really delicate balance for me, because when I go, I want to be part of a community which I am part of, but equally I have to be mindful that my presence brings with it the taint of research, and I have to think about which hat I'm wearing when I'm in any situation. So joining Facebook groups, for example, I joined with a symbol that said I am a PhD researcher, and I did not join any groups that were specifically supportive in certain ways. I did not
Kept
join
yourself
any.
neutral. You try to keep yourself neutral.
I tried to make sure that I was really clear. And I started out thinking I'd use a thing called netnography, where you bring in social media posts. And then when I started looking at them, I thought, actually, this is incredibly intrusive. And I think this is unethical, because I'd be capturing people's personal pain that they haven't consented. And I don't think
though they've published it,
yeah,
it's not published for the use, is it? For others to use it.
Legally, you can do it, but I felt morally and ethically that was not cool. 5 minutes left. So,
now.
so I really managed those boundaries very carefully. So when I went up to the inquiry last week, I was really mindful that I was going as me, not as a researcher.
Yeah.
And the thing that has really carried me through is being absolutely furious. And I've got increasingly furious the more I've
But it's
discovered.
giving you that energy, hasn't it, to really get this done?
Yeah.
I have to say, from what you explained to me, bias is always an issue when you're doing research, and particularly when you're in position of the person, and your auto and infographic is way of handling it. But I was actually really, really impressed by the way you've handled that that sort of bias and that insight. Actually, I think it's given a richness. Sounds like it's given a real richness to your research. Sally, and how far off are you doing your Viva?
I'm writing up now, so I'm doing the joys of writing everything. Liz Ross and I were talking about when my Viva is, and it's sort of an ethereal soon, but don't be pressured.
It took me a year to write the introduction when I did mine. It drove me insane.
I've got most of my introduction set up.
Oh, there you are. Be all right then.
I'm writing up a methods chapter of sorts. I've got my findings journal article that has got revisions to do. So it's I can't tell how much is there and how much isn't at this point.
I know that, but it's lovely when you just seem to get over this hump and then you see the end in sight. So so you're doing really well. Interesting. One of our funded PhD students that we've got is actually doing a autoethnographic study as well.
Oh, brilliant.
She's doing a study into cancer in ethnic minority, particularly Asian communities.
If I can help, shout.
And I was just thinking it might be interesting to hear how you've managed it, because she's obviously herself suffered with cancer, which she's open about. And she feels that really adds a benefit to the conversation she's going to have.
I think it
does. Sounds to me like your methodology is really similar to her, so it might be useful if we get you talking to each other.
Pop us in touch.
Yeah, we'll do. So
I'm always happy to get someone to join the cult of autoethnography, frankly.
Yes.
And I think Emma's looking at the clock.
I know she
is. Sally Ann, so just to reassure you, this will be recorded, and obviously, and just checking you're happy for it to be included on the One Gloucestershire research page. And I think people will look at this at their kind of their leisure. I'll make sure that I'll let people know that it's there. It's gone up onto the webpage. It just takes a couple of days for comms to kind of do that. But yeah, before we get cut dead, because it literally does cut you dead on Zoom.
It does.
But just wanted to really thank you, because it really felt like a really heartfelt presentation.
Thank you for having me.
It came from a really kind of loving place, and I just wanted to thank you for that. It was really.
I think we've learned an awful lot, both from a research methodology point of view, but also from actually a real insight into what traumas these individuals are going through, and the generations ahead as well. So thank you very much, Sally Ann. It's an excellent piece of work.
Thank you for having me and engaging so beautifully, both of you.
Oh, well, thank you, and have a nice evening. The sun's still shining out there, so yeah.